brought a resolution, Jamaica co-sponsored with a few other countries, calling on the globe through the WHO to enhance bilateral arrangements. Some people say, why not train more locally? We can't train more locally because while we can train in the classroom on the theoretical stuff, once they get into the hospitals for the clinical training, we don't have enough infrastructure to support. So unless we build out more hospitals. So one of the things we're working on is to train them in the classroom on the theory and do exchanges with other jurisdictions, other countries, so they get the clinical side of the training in the hospitals in other jurisdictions. In fact, we're making some progress. I'm supposed to be in the UK in another 2 weeks, week and a half, to try and conclude an arrangement with that government for some of our RNs to go to the UK and train in the hospital system and then have an exchange program where they work here and there. And we also are doing the same thing with Cuba in order to expand the cadre. We have no difficulty in training for export, but we need to train more, and that requires collaboration. So that's a major issue. I'm told I have 5 minutes. I hope with some leniency given the difficulties we've had. In terms of the diaspora contribution to healthcare, the next slide should show that in 2016, the diaspora contributed approximately $8 million in value to public health, whether through missions that came to Jamaica or donations of material, beds, motor vehicles, whatever it is. But the diaspora does play an important role in helping public health from where you are situated in your country. So far this year, we have seen about $6.7 million in value, and that's growing, obviously. We still have some time left. How is that contribution transmitted to Jamaica? We have in the ministry a health and wellness foundation. It's a registered charity, and we recommend to diaspora members and organizations who are interested to contact that entity for any offers to contribute, even if you want to direct the contribution to a specific institution in the public health system. Work it through the central ministry, because that will allow us to provide better guidance in terms of bringing those things in. There are benefits to shipping through this wellness foundation. You can get the appropriate write-offs of duties and so on. Some of those arrangements have changed recently because of new IMF restrictions, which is all the more reason why a discussion should take place in terms of getting that information through the Wellness Foundation. We have launched a program, next slide, to engage the diaspora in a more meaningful and long-term way at the level of primary health care. That program is called Adopt a Clinic. We can discuss more on that, but essentially what it is, we have 320 approximately primary health care facilities in communities across Jamaica. We have taken out 100 of those, profiled the needs of those institutions, and we are promoting members of the diaspora or local entities or individuals essentially adopting that facility. And what that means is a commitment of a certain amount of resources for routine, not major, routine maintenance to ensure that the facility functions, and an appropriate level of recognition to those persons or entities who have in fact adopted that facility. So far to date, we have about 30 adopters or proposals for adoption, including I think about 9 out of the UK. I don't have the numbers for the US, and we have about 15 or so local entities. So it's working, and we would like to discuss more about that. There's a booth outside that provides additional information. But there are so many missions that come to Jamaica each year to do healthcare work. Identifying with a primary healthcare institution, we think, would provide additional benefits for that purpose. The gift policy stipulated here, again, if you make contact with the Health and Wellness Foundation, and there is a website that we're building out which will give you that information, it will stipulate what's the best approach. What I'll say on this slide quickly is that the difficulties we have with persons wanting to give is that oftentimes when they make contact with us, it is after they have themselves taken certain decisions on what they are going to give and how they're going to give. So, for example, someone will call you and say the product is already in transit, or is it at custom, or they're at the airport and they want assistance to clear. Oftentimes, depending on who it is shipped to, the method used, and other reasons, it becomes very difficult to maneuver the bureaucracy that exists within the system. Sometimes a bureaucracy that is stipulated. In this case, we have an IMF agreement as to what is allowed to be brought into the country without paying duties. So it is better, or to emphasize, best for you to make contact before and then be guided by the information that we provide. In addition to that, we have embarked on a needs assessment of the public healthcare system, which will give you some ideas as to what to give if you decide that that is what you want to do. So you know exactly that you're giving to areas that actually need it. On the investment side, again, there's a booth outside that will give you more information on this. I know time is going. But we have an ambitious plan to overhaul the public health infrastructure, which includes building out or upgrading hospitals. And there's always opportunities for private-public partnerships. And we are willing to listen to anybody who may have an idea, or investors who may want to add to the menu of services or infrastructure that is required. We are working currently and well advanced in terms of putting in oncology infrastructure, LINAC, both in Montego Bay and Kingston. And we are pursuing public-private arrangements to manage those facilities, state-of-the-art facilities. We are looking at other diagnostic services in dental and optical that is required. We have had a few offers from persons who would like to establish some of these facilities. And the public-private arrangement, we feel, is a real option because, frankly speaking, the government cannot afford sometimes for the capital outlay to secure this infrastructure. The training of personnel, nurses, is an ongoing effort. As I had said earlier, we are developing some bilateral arrangements if there are members in the diaspora who have strong links to institutions or states or countries and can influence that level of exchange for training. We would certainly welcome a discussion there because, frankly speaking, until we build out more infrastructure, the clinical side of training is restricted or restricts us from recruiting more persons. And there are a lot of Jamaicans who would go into healthcare, but we have to limit the numbers depending on what is available. I'm going to stop here because time is on us, and I'll be available for any questions that you would like answers to. Thank you very much.
Thank you very much, Minister, for laying out what's a clear policy and strategy. And I think the wide-ranging consultation you have done with the healthcare workers has led to, I think, a plan that's workable for us in healthcare. We'll take the questions at the end of the session. So what I'll do, I'll proceed to our next speaker, Dr. Vincent Reed. Vincent is a surgical oncologist. His current appointment is surgical oncology director at the Mercy Medical Center in Cedar Rapids, Iowa. He has a special interest in head and neck cancers, breast cancer, melanoma, that's skin cancer, colon and rectal cancer, and soft tissue sarcomas. He did his fellowship at Albert Einstein and has worked at
the help with which the diaspora can offer in building out infrastructure and specialist areas in cardiology, oncology, nephrology, and radiology.
The minister also touched on the Adopt a Clinic program, which is where members of the diaspora can actually contribute to primary health care in Jamaica.
Distinguished panel and guests, it is my distinct privilege to address this body today. What I'll do is I'll try to outline some of the common cancers that affect people of the diaspora and talk about some treatment options. And I will stick within my time limit so that So breast cancer is certainly one of the more common malignancies that I treat, that is treated. In North America, 1 in 7 women will get breast cancer. And this slide probably projects it a little poorly, but while the rate of breast cancer is lower among particularly women of color than among our Caucasian partners, what you will find over time is that the outcomes are poorer among women of color. And that gets into an entire discussion about the genetics of breast cancer, and that there is enough data out there to suggest and to show that breast cancer among women of color may be a very different disease from it is among our Caucasian partners. The tumor markers are different, and therefore the progression of that disease is quite different among women of color, despite our lower incidence. So the main weapon that we have to detect breast cancer is mammography, and we usually combine mammography and sonography for the additional details. And you know, when you look at this long enough, you will be able to look at a mammogram and see right away that the thing on the right of the screen is a malignant spiculated tumor, while the well-defined lesion on the left would be something like a fibroadenoma that's benign. But you know, what we want to do is to be able to detect breast cancer at this stage, at the stage where it's an imaging abnormality, and not at the stage when it's a cancer that's growing into the chest wall or growing through the skin, because that limits our options at that point. And herein lies the reason why early detection is important. You go from 90% 5-year survival at stage 1 to 15% or less 5-year survival at stage 4. So that is why early detection and early treatment is optimal to the outcome. So we looked at many aspects of breast cancer. One of as a surgeon, one of the surgical options with regards to treatment of breast cancer is to remove the cancer with a rim of normal tissue around it. That's called a lumpectomy. The other option, the more aggressive option, and the option that we'd certainly like to use much less, is removing the entire breast. Because with removing the entire breast comes the issue of reconstruction. I have a lot of women in their 40s, and to tell a 44-year-old woman that you're going to remove the entire breast and she's going to be flat-chested is a little bit of a challenge. So that reconstruction is a major issue, and the availability of plastic surgeons to do the reconstruction is a major issue. One of the platforms that I've been involved with is something called a margin probe that we use to detect cancer margins intraoperatively. And to be able to tell us that we have adequate tissues. This is early on in the process of looking at cancer margins, and I looked at my own personal data. In the United States, for example, the re-excision rate after lumpectomy is 18 to 24%. My personal re-excision rate was about 14.9%. And this is my personal data of the first 21 cases, where I was able to reduce my re-excision rate from 14.9% to 0% using the margin probe technology. And subsequently published that data in peer-reviewed journals. This is our publication from the American Journal of Surgery, looking at the re-excision rate as directed by the margin probe. This was subsequently picked up and published by the Wall Street Journal with an entire article talking about margins and the various aspects of margin reduction. So the lessons I think that is important for a body like this in terms of approaching cancer is, one, the centralization of care and expertise. I don't think if you have budget or issues or limited budget that each hospital can be all things to all people. I think it is important that, I've spent some time in Germany, for example, where they now have about 8 to 10 centers that does most of their breast cancer, because they have centralized the care, they have centralized the expertise. So, one hospital may be a women and children's hospital, and most of your cancers go to that hospital. Also, you're able to centralize the expertise with the limitation in number of healthcare expertise that we have. Another important thing that I think we need to do is to look at our tissue, because the tissue that we collect, for example, in the operating room today is really going to direct what we do in years from now with regards to treating cancer. Years ago, 25 years ago, I saw at Memorial Sloan Kettering when they started collecting sarcomas. Everyone thought they were crazy. But today, most questions that are answered in the world regarding sarcoma treatment goes back to that cancer database. So if you have the tissue, you always have those cancers, and there are various manipulations, genetic manipulations, and studying new and robust techniques. There are various manipulations that you can do to look at the cancer tissue and to make a determination about treatment. One of the other cancers that disproportionately affect people of color is head and neck cancers. And this is a young woman with a left lateral tongue cancer. This is after the resection of a left lateral tongue cancer. And the treatment for a lateral tongue cancer is to resect versus something at the base of the tongue where you give radiation. So these can be very, very deforming operations and lead to significant functional results. Here is someone with a cancer of the vocal cord. Another example is someone with a cancer of the tonsil. And these cancers are in very difficult locations. And when you resect these cancers, certainly you have very, very significant functional issues. The current treatment has to do with giving them radiation and chemotherapy in what we call the adjuvant setting, meaning after treatment. So what are the risk factors from some of these cancers? The good thing is that a lot of these risk factors are modifiable. Usually, if taken in the right concentration, it is lethal. So the cigarette is a marvel because you're able to put all of these things together in the right components, making it addictive, and people can at least survive the daily use of cigarettes. But as we know, they have significant impact on cancer rate overall. So cigarettes, certainly alcohol is another significant one. Another one that's becoming more and more relevant is the human papilloma virus. The human papilloma virus, as we know, is sexually transmitted. Certain kinds of viruses are what we call oncogenic, meaning leading to cancer. So, so we're very aware of the smoking, we're very aware of the drinking, we're very aware of these, at least these cohorts of the human papilloma virus that leads to